Okay, so I'm happy we're all here. It certainly feels like kind of a crazy time in the world, but we can focus on the present. It's my pleasure today to introduce Dr. Nate Chin, who's visiting us from the Department of Medicine and the Division of Geriatrics and Gerontology at the University of Wisconsin, where he's an associate professor. He sees patients in the UW Health Memory Clinic, and he's also an associate program director there. He is medical director of a number of dementia-related projects and studies, including the Wisconsin Alzheimer's Disease Research Study, and then plays leadership roles in their ADRC there. And I think, for a number of reasons, I'm personally very excited about today's talk, but foremost among them is I think we'd all agree that we need more translation between geriatrics and the kind of specialty of memory care, which is part of what we do, but also part of what other specialties and fields do. And I think Nate is a really good translator of what's happening at the cutting edge. And then I think very importantly, for all of us who are podcast lovers, he leads a wonderful podcast called Dementia Matters, which has pithy, quick episodes that I'd recommend to you on a variety of dementia-related topics. So I guess the last thing I was told to plug his Blue Sky account today, because that is our requirement for today's lecture. So thank you, Nate.
Thank you for that introduction. And thank you all for being here in person and virtually, wherever the virtual people are. It's been a wonderful day, and I really appreciate all the people who have spent time talking to me. And I'm really grateful for the opportunity to be among such esteemed colleagues here, presenting on a topic that I've struggled with and that I think about on a regular basis, and that being Alzheimer's biomarkers, monoclonal therapies, and where geriatricians fit in providing care in this new era. And when I think of new era, before I move on, I will say that for the first time ever, I saw a Waymo car, and you guys are living in the new era. I don't think I'm ready. I know I've been encouraged to try it, and I don't think I can do it, but we'll see. We'll see. So I'm going to move on to my next slide. And these are my learning objectives, and for the sake of time, I'm not going to read them out loud. I do not have any relevant financial disclosures related to this presentation. I would like to spend a couple minutes up front talking about the WRAP study, the Wisconsin Registry for Alzheimer's Prevention Study, because I'm going to be using data from this study to talk about Alzheimer's biomarkers. And so the WRAP study is one of the world's longest running studies of individuals at risk for Alzheimer's disease. Proudly, it was started in 2001 by a geriatrician. And we now have 1,900 participants, and they come in every few years for about 6 hours of an assessment. Now, at risk is being defined as having a parental family history. And you can see this, yes, you can see from the right side of the slide, primarily they're based in Wisconsin, but they do come from all over the country. And WRAP is known for having a young cohort, but you can see they have matured. So they are on average 67 years old. And on average, WRAP participants have been in the study for 11 years. However, we have many that have been in the study for decades, at least 2 decades. Now, about 22% of our WRAP participants are from underrepresented groups. About 70% of them are female. As is the intention, 73% of them have a family history of Alzheimer's disease. Because of that, we do see more individuals having an ApoE4 allele, so 41% compared to the general population, which is about 20 to 25%. The WRAP participants represent the United States population when it comes to general health factors. So I'm thinking about obesity, high blood pressure, diabetes, and cholesterol. And I say that because in the past, it's been asked if WRAP is healthier than other participants. Now, WRAP is focused on biomarker research and identifying the earliest biological and cognitive changes in individuals. And one of the strengths of WRAP is that it has longitudinal biomarker data, so scientists can actually study change in these participants. So specifically, WRAP participants, 900, have generated almost 3,000 MRIs. 700 participants have generated 1,500 PET scans, 1,100 tau PET scans. I should say 1,500 amyloid PET scans, 1,100 tau PET scans, and 1,900 participants have generated almost 9,000 visits of health factor data. So that's rich data that we can study. So then why exactly am I here? Well, it's because of one of your very own. So back in August of 23, Dr. Eric Wadera contacted me out of the blue without knowing me, and he invited me to join him in writing an editorial for JAMA. I'd never written an editorial or been published in JAMA. So of course, I jumped at this opportunity. And we published what I think was a very fair and balanced piece where we commented that we were in this new era of treatment. The FDA had approved aducanumab, which we said there were many issues with this, but they had also approved lecanemab, and its phase 3 study seemed solid that these drugs can remove amyloid protein, that there was less worsening in cognitive decline, and that led to perhaps less change for them. We weren't sure what that really meant, but we did know that ARIA was real and that seemed concerning. But our take-home point was that the clinical world was not ready for these drugs and that system-level changes were going to be needed in order for implementation. Now, a few weeks later, I was invited by Alex Smith and Eric to be on their fantastic podcast, Jerry Pal, along with Sharon Brangman, who's the other author, and then Jason Karlowicz, who's a very thoughtful and opinionated geriatrician. I say that because I know him well. If he's watching, I'm sorry. And we were all very critical of the trials and the drugs in the absence of appropriate social support for our patients. But there was this moment where Alex asked all three of us, well, are you going to prescribe these medications? And there was this awkward silence, and we all said yes, for certain patients and for certain reasons. And so after the podcast was released, I noticed I had negative social media feedback. How can geriatricians favor such drugs? They've lost their way. They've lost their principles. Shame on them. And I was taken back by that. I'm a geriatrician. I've never received negative feedback like that before. And so then I asked the group to write a different commentary with me for JAGS on how geriatricians could utilize their skills and talents in the context of MAB treatments. And I'll make some of these points later in the talk. My hope was to actually bring geriatricians together, and I'm not really sure that happened. And Eric and Jason told me not to look at social media after it was published. So of course I did, and it was worse. I read somewhere that I was bought by pharma, that I didn't know what I was talking about, and that I was an anti-geriatrician. I'm not sure what that is, but I was an anti-geriatrician. And that really hurt. And it caused me to ask the question, what is the role of a geriatrician in this new era of Alzheimer's disease? So what I'd like to do for you today is define what is a geriatrician, not because you don't know what it is, but because I actually had to go back and look at it because I was really questioning it. And then I want to make two really important points and define and justify them. One is that Alzheimer's biomarkers are incredibly powerful tools and should be used by experts at the right time and in the right patients. And that monoclonal therapies have a place in treatment and can do what lifestyle interventions cannot. Ultimately, geriatricians have a place in this treatment from primary care to specialty care. So what exactly is a geriatrician? So I went back to 2014. There's this amazing paper by Dr. Lipsig and JAGS. And so what they did is they looked at 76 geriatric curricular milestones for geriatric medicine fellows. So these are the expectations we have for fellows. And they took geriatric leaders in AGS and academic programs, and they developed a set of EPAs in trustable professional activities, which I've come to learn are core work of a specialty, the talents and skills of a specialty. So for the next 2 years, they presented at meetings, they had expanded working groups, and they approved 12 EPAs. And I'm going to show you 9 of them. So geriatricians provide patient-centered care that optimizes function and well-being while integrating patients' goals, values, comorbidities, and prognosis. They assist patients and families in clarifying those goals of care and making care decisions. And they're very focused on geriatric syndromes. That's falls, dizziness, cognition, pressure ulcers, sleep, hearing and vision, weight loss, constipation, elder abuse. Geriatricians provide comprehensive medication review. There is nothing better than deprescribing. We provide palliative and end-of-life care. We coordinate care across the many different healthcare settings because we are masters of multimorbidity. We skillfully facilitate a family meeting and we collaborate and lead interdisciplinary teams. How can you not be proud to be a geriatrician when you look at the skills of what we have? I went a little bit deeper and I looked at what our geriatric curricular milestones are for cognition specifically. And so we expect our fellows and therefore ourselves to be able to differentiate normal aging from MCI, from the various stages of dementia, from delirium and depression. We expect ourselves to perform, interpret, and articulate the strengths and limitations of the tools we use for cognition and mood. We need to know when to make the appropriate referral for psychiatry, for counseling, for neuropsychology, and then use those findings in our plan of care. We have to know when to diagnose and manage the reversible causes of cognitive change, particularly depression. We have to manage and we'll diagnose and manage the causes of dementia, and then care for our patients from beginning to end using anticipatory guidance in their goals of care. And then certainly we have to assess and manage cognition, function, and PPSD. We provide comprehensive, holistic care for patients with cognitive impairment. And so what do I mean by cognitive impairment? And I'm going to use the NIA-AA 2011 criteria. A person who has a cognitive change that's a decline from their baseline is noticed by them, their family, or the clinician. There's an objective form of impairment on testing, and then there's function. And we are experts in function. So in MCI, there's functional independence, albeit maybe some inefficiencies. But in dementia, there is a functional disability. There's a functional dependency and an instrumental activity of daily living, and then progresses to all of them due to cognition. MCI is a broad category. It allows for neurodegenerative conditions, but also medical problems, medication side effects, and mood. Dementia does refer to a brain disease or a brain injury, and so it's chronic, it's persistent, and it's progressive. So that's cognitive impairment. So then Alzheimer's disease. Alzheimer's disease we think of as that neuropathological condition. So the presence of amyloid plaques outside of the neuron and neurofibrillary tangles inside of the neuron, leading to cognitive symptoms, the memory loss. But I would ask us to think a little bit deeper about Alzheimer's disease as a biological process that's happening in the brain. It has a sequence of events. And yes, it does start, or at least the first identifiable part of that process is the buildup of elevated amyloid. And we can pick that up in a PET scan, in spinal fluid, and now in blood. And then some time goes by and we can pick it up on a tau PET scan or in the same other biofluids. And the more time goes by and there's some synaptic dysfunction, there's accelerated neuronal death. And we can pick that up too with an MRI scan, a CT scan, spinal fluid. Now, all three of these things occur above this hypothetical green line because you don't actually have to have symptoms for them to be occurring. They're asymptomatic. And this is not new to medicine. In diabetes and hypertension and HIV, there's asymptomatic phases. But at some point, the neural networks become too dysfunctional. The neurotransmitter deficit is too great, and a person does develop symptoms. And so they cross over that green line. Hopefully they go in early enough and they're diagnosed with MCI. And because we can't stop this disease right now, they continue to progress and they're diagnosed with dementia. And this is a picture of my father when he has moderate stage dementia. And I put that picture in as mostly a reminder to myself that I'm talking about one process, amyloid tau, neuronal death, but there's clearly other processes happening as well. There's something happening before amyloid that leads to the buildup of amyloid. There's something between amyloid and tau. And there's something beyond Alzheimer's disease. There's other diseases of the brain that are leading to MCI and dementia. And for my father, it was Alzheimer's disease and it was Lewy body disease. And so there are other diseases we need to be thinking about as well. Alzheimer's, Lewy body, vascular, frontotemporal, Parkinson's, Huntington's, and then a whole slew of other conditions that affect the brain. Alcohol, and then now this new one, late, limbic, predominant, age-related TDP-43 encephalopathy. It's a mouthful. They just came out with the clinical criteria for this. If you're interested, I have a podcast on it. Thank you, Dr. Wolk. But what I really want us to focus on is this squish circle in the bottom, mixed dementia. This is our default. In our patients who are 75 and older, this is what we're going to see more often than not. People are going to have multiple diseases causing their symptoms and their impairments, not pure disease. And the reason I say that is because this is what the evidence is bearing out. This is a really important study last year, 2024, using NAC data. So NAC stands for National Alzheimer's Coordinating Center. All of the ADRCs, the Alzheimer's Disease Research Centers, send their data to NAC. That gets cleaned and it's usable by scientists. And in this study, there were over 2,000 brain autopsies, and you can see the different pathologies. You have Alzheimer's pathology, you have frontotemporal disease pathology, you have Lewy body, you have late. But for simplicity's sake, let's just look at this circle, because what it shows is that 35% of the time it was just Alzheimer's disease. 65% of the time it was mixed, Alzheimer's plus TDP-43 or Lewy body or both. Interestingly, almost 50% of the time it was Alzheimer's plus Lewy body. This is where my father would have fallen. Now, the weakness, if there is one of this study, is that they didn't account for cerebral vascular disease. And we know that Alzheimer's co-occurs with cerebral vascular disease a lot. In 2 years prior to this study, in the same, well, not the same, but in NAC data sets, in 2,400 brain autopsies, we see that 61% of the time, Alzheimer's and cerebral vascular disease co-occur, and 39%, it's Alzheimer's without cerebral vascular disease. And they're defining cerebral vascular disease as moderate to severe arteriosclerosis or atherosclerosis. Now, interestingly and importantly, people with both diseases decline faster. And we see this in the WRAP study as well. This is a paper currently being reviewed by Dr. Leon Du, where on the x-axis you have age, on the y-axis cognitive change, so you're declining as you go top down. I think the most important thing for us to see is the gray line. Those are individuals with Alzheimer's and vascular disease. They're declining faster than those with just Alzheimer's, or the yellow are those with just vascular. The reason I bring up mixed dementia is because it's more common than people initially thought, but it also impacts the symptoms people have. So it makes it harder to understand what's actually happening in the brain. And so there's this popular study that came out last year in October in JAMA by Dr. Palmquist and others. And I say popular because it hit the media, the lay public, and they had sensationalized titles like, "Is the blood test better than your doctor?" Of course, I'm offended by that title. No, the answer is no, of course. And I want to be mad at the doctor, at the scientist, but that wasn't the purpose of the study. The purpose of the study was to compare a blood-based biomarker in clinic to see what it was like in a clinic population in Sweden. So what they did is they took this blood test and they looked at it in the clinic and they compared it to spinal fluid. That's their gold standard or their biomarker. But at the same time, they did ask the clinicians, do you think your patients have Alzheimer's disease pathology based on the history, the exam, a CT scan, and cognitive testing? And in primary care, it was a mini mental or MOCA. And in specialty care, it was about a 45 to 60-minute cognitive test, a fairly good test. And you can see the results here in this slide. So in the right here, I just highlighted the accuracy part. In primary care, is 89% accurate, the blood test, and the primary care physician was 58% accurate. In the specialty care, the blood test was 92% accurate, and the dementia specialist was 71% accurate. So there are two conclusions where, one, the blood test is fairly accurate at detecting Alzheimer's pathology, and two, clinicians are struggling to detect Alzheimer's pathology, not the syndrome of MCI dementia, but the pathology. And I think those are fair conclusions based on their data. I do not think it's a fair comparison to compare a blood test designed to detect pathology to a physician. That wasn't the purpose, but that's where the media, of course, got it wrong. So some of my key takeaways so far. Alzheimer's disease is a biological process composed of amyloid and tau causing MCI and dementia. MCI and dementia are defined by key clinical features with many causes. Mixed dementia is common. It impacts the clinical presentation in the course. And so using a clinical history and cognitive testing, our diagnostic accuracy for Alzheimer's pathology is limited, about 60 to 70%. And so a gap exists, and we need better tools to identify the causes of MCI and dementia. And this is where I think biomarkers are important and can fill that gap. And we are all comfortable with biomarkers because we've ordered hemoglobin A1Cs and lipid panels. And it is different, I know, but biomarkers are objective measures collected from the body that reflect either an abnormal or a normal process that's occurring. They can serve one or multiple functions: diagnostic, monitoring, response to therapy, even predictive. And in Alzheimer's disease, we've had non-specific biomarkers. We've had structural brain imaging. And this is an image of this is an MRI image looking at the hippocampus. And it's a sequence of them. So this is time point 0, 1 year, 2 years, and we're looking at the hippocampus labeled H, and we're seeing hippocampal atrophy over time. And in my training, hippocampal atrophy was Alzheimer's disease until proven otherwise. That's non-specific. We're not finding the proteins of Alzheimer's, and we didn't know about late at that time. So we do have more biomarkers that we're looking at, better ones. And so in this figure of a neuron, the two Alzheimer's disease specific biomarkers are going to be amyloid and phospho-tau, but we do have other ones. We're looking at axonal injury, and that's neurofilament light here. We have biomarkers looking at synaptic dysfunction. We have biomarkers looking at inflammation. GFAP is a common one. We have biomarkers looking at activated microglia. There's lots of them that are being studied in research. Some of them are being used in spinal fluid clinically, and now some of them are being used in blood, with the p-tau species being the ones you're probably hearing about in the news, p-tau 217. We still have what I think is the gold standard biomarker, which is the PET scan. And you can see images of an amyloid scan, negative, positive, and a tau PET scan, negative, positive. And then we were seeing more amyloid scans because they are being used to determine eligibility for monoclonal therapy. So why exactly are biomarkers so important in diagnosing cognitive impairment? Now, this is a trick question. I'm just trying to make sure we're all following me here. They're not important. Clinicians are important. A history is important. Cognitive testing is important. But biomarkers are important in identifying the etiology of what could be going on in the brain, contributing to those symptoms and impairments. And I think a good example of the impact of biomarkers on clinical care comes from one of your very own. So Dr. Gil Rabinovich, a neurologist here, created the IDEA study, and he published this in JAMA 2019. And so the IDEA study, Imaging Dementia Evidence for Amyloid Scanning, a single group, multi-site, longitudinal study, assessing the association between learning amyloid PET results and subsequent change in clinical management of Medicare patients with MCI and dementia. Now, the learning of the amyloid PET result was not the patient, it was the clinician. How does the clinician learning that result change management? Primarily drug therapy, but also counseling about safety and future planning. Now, as a side note, when I was a geriatric fellow, the study was going on, and my clinic mentor let me participate for the full year. And it's actually this study that got me interested in biomarkers in clinical research. And we can see some of the results from this study. Now, this is the level of impairment at baseline. So I want us to just focus on the left side here. These are all patients with MCI. And these are all patients, what I'm highlighting, who have a positive amyloid PET scan. The dark bar, about 40%, this is pre-PET scan. They were on drugs for Alzheimer's disease, so likely an acetylcholinesterase inhibitor. Post-PET scan, learning that they had elevated amyloid, most likely Alzheimer's disease, you can see that changed management. About 80% now were on drug therapy. We see that it didn't really change drug therapy for those that had a negative PET scan. And we see a similar trend for those patients living with dementia. Now, ultimately, 85% of the time, physicians felt the scan changed their management. 35% of the time, the diagnosis actually changed. And when it did change management, drug changes were the most common, but it did lead to improved diagnostic confidence, a reduction in other tests, and more clinical trial referrals. And this is excluding the impact on the patient and the family in having more certainty in what's happening in their brain. So I've been referring to amyloid as positive or negative, elevated or not elevated, so a binary piece of information. But there's actually another important or two other important qualifiers, and that's amyloid onset and accumulation. If we're thinking about Alzheimer's as a biological process, we want to know when it becomes elevated and what happens afterwards. And because of the great research happening, we actually are able to understand this a little bit better. And in RAP, we've been using amyloid PET scans since 2009. And so what I'm showing you here is relatively old data from 2020, but you can see all of our amyloid PET scans. So there's hundreds of scans represented here. And so age is on the x-axis. On the y-axis is the amount of amyloid in that PET scan. Now, the dot represents a participant. A line is one participant who's had multiple scans over time. If it's black, if that participant never became elevated. If it's red, that participant eventually became elevated. That defining line is right here between elevated and not. And this is our data. Now, because of two great and impressive algorithms, one called group-based trajectory modeling and another called SILA, and please do not ask me about what they do. I'm not capable of explaining them. They were able, though, to convert this data into chronicity of amyloid presence. And so the y-axis, the amount of amyloid stays the same. So the burden or presence of amyloid is the same, but on the x-axis, it's different. So I want us to look at 0, because everything to the left of 0 is still not elevated amyloid, but everything to the right of 0 is elevated amyloid, but amyloid for 10 years, for 20 years, for 30 years. And what we see is this really nice, smooth, clean line. And two important findings or conclusions can be made from this. One is that once you become elevated in amyloid, it continues to rise at a predictable rate. We call it the amyloid escalator in Wisconsin. Other people call it an amyloid clock. The other is that from one PET scan alone, we can give you a pretty good estimate of how long you've had amyloid in your brain and therefore the age at which you developed elevated amyloid. We're getting to that point of defining that process, this biological process of Alzheimer's. And I know what you're thinking. This is unique to Wisconsin. This is the data that you have from your longitudinal finding. It needs to be reproduced. I completely agree with you. And it has been. The amyloid escalator has been shown in the WashU cohort, the Mayo Clinic cohort, the Baltimore longitudinal cohort, and the ADNI cohort. Once you become elevated in amyloid, you continue to rise. Seems pretty consistent now. I'm only talking about amyloid. And I'm defining Alzheimer's disease as amyloid and tau is really important. And so what is the relationship between amyloid and tau? And so in this figure, and this comes from Dr. Carly Cody, on the x-axis is that amyloid chronicity. So everything to the right is elevated amyloid for 10 years, for 20 years, for 30 years. Everything on the y-axis, now we're talking about elevation in tau in the earliest part of the medial temporal lobe called the entorhinal cortex. This is where we think it's really important. This is the beginning of tau. The defining mark of elevated is this dotted line. So everything above is elevated, everything below is not. If you're in blue, you're cognitively healthy. If you're in orange, you have MCI. If you're in red, you have dementia. And there's 3 key findings here. The most important is this red circle. In over 600 RAP and ADRC participants, if you have amyloid for more than 23 years, no one goes without developing tau in the entorhinal cortex. And I know what you're saying. Well, what about this individual? They now have tau in their entorhinal cortex. This is just our cohort, but 600 people. It's a decent number. The second finding we have is 10 years seems to be pretty significant. After 10 years of having elevated amyloid, we tend to see more people with MCI and dementia. Something about that. And the other thing that's important is, on average, once you become elevated in amyloid, it takes about 7 years to develop tau in your entorhinal cortex. And this has been reproduced in other studies too. So we're starting to see this timeline of Alzheimer's disease based on the biomarkers. But what about amyloid tau and cognitive decline? So this is the same cohort now. Age is on the x-axis. Cognitive trajectory based on this PAC-3 score is on the y-axis. And now we're breaking people up into those who don't have amyloid, those who have amyloid for less than 10 years, those who have amyloid for more than 10 years, and then those who have tau in their entorhinal cortex. The most important finding you can see is the purple line. Those who have amyloid for more than 10 years and also have tau in that entorhinal cortex, the earliest part, they are declining rapidly compared to everyone else. And in fact, at age 70, they are declining 3.5 times faster than the same group that has had amyloid for also more than 10 years, but does not have tau in their entorhinal cortex, suggesting there's a synergistic relationship between amyloid chronicity and tau in the entorhinal cortex. And we're also seeing more of this precipitous decline in these individuals years before they actually develop clinical impairment, because all of these individuals are technically cognitively unimpaired. None of them had MCI yet. The last data slide I want to show you comes from Dr. Heston, who's here at UCSF doing her postdoc, and Dr. Toby Bethauser. And what they're doing is looking at development of dementia, anchoring it to the duration of amyloid and tau. And I want us to focus on this slide here. So these are 384 participants in ADNI. All of them have amyloid, about half of them have tau. And what we're looking at here is, this is 5 years of amyloid, 10 years of amyloid, 15, 20, and 25. And on the y-axis is the probability of being dementia-free. So up here, no one has dementia. Down here, everyone would have dementia. And we just see that over time, as you have amyloid longer, the likelihood of developing dementia is higher, or being dementia-free is lower. I think you've heard enough about that. But this is the part that I really wanted to show you, which struck me when they presented it to me. So this is 190 participants. All of them have amyloid and tau. And now we're looking at tau duration. So tau for 5 years, tau for 10 years, tau for 15 years. It's a steeper decline to developing dementia. And no one who has tau for 15 years goes without developing dementia. No one escapes dementia in a small set, 190 people in one study. And this hasn't been reproduced yet, but this looks scary. If you have amyloid and you have tau and you have tau long enough, you're developing dementia. So what does this mean? Well, to me, I see this and I think having amyloid and tau means that if you're having symptoms, they're at least partly due to Alzheimer's, if not primarily due to Alzheimer's. It means that future decline is likely on cognitive testing. It means progression to dementia is more likely. And I think this information would matter to someone as they're thinking about their future, especially someone who's got a family history. As a clinician who's taking care of someone with symptoms, I think that would matter too. It might validate their symptoms. It might impact their willingness to engage in treatments and clinical trials. It might motivate them to engage in lifestyle changes. Certainly could impact advanced care planning or management of other conditions. This is the power of biomarkers in the right context. But there's also a practicality aspect. Biomarkers are actually needed if you want to talk about monoclonal therapy. It's a part of the eligibility criteria. So currently, if you want to consider monoclonal therapy, you have to have a diagnosis of MCI or mild stage dementia and confirmation of elevated amyloid on CSF or a PET scan. There's also the possibility that amyloid biomarkers could be used to stop monoclonal therapy early. And this was done in the Trailblazer-ALZ 2 study, where a good percentage of people were able to finish treatment earlier than the 18 months at 1 year. If you believe that possibly monoclonal therapy might need to be more like chemotherapy in its rounds of treatment, well, then amyloid biomarkers might be used in between that to determine when a person becomes elevated. There's a phase 2 study, prior study, with lecanemab, where between the treatment period and the open label study, there were years that went by. And they actually did PET scans and blood tests, and they showed amyloid slowly accumulating, roughly 3 centiloids a year. And so they were able to monitor that. But I think the more impactful use could be the fact that amyloid and tau levels may actually inform us who's the best to respond to treatment. So in the donanemab study, Trailblazer-ALZ 2, they separated people into those with low, medium tau levels and those with high tau levels. And those with low, medium tau levels responded better to treatment. And I use that as my segue into saying that monoclonal antibody therapy can effectively remove amyloid protein. And so these are the obligatory slides from the phase 3 studies. So this is Clarity AD using lecanemab. This is Trailblazer L2 using donanemab. And in both of these, time is on the x-axis, roughly 18 months. And on the y-axis is the mean change in amyloid removal on the PET scan. And they have this unit called a centiloid. It's a way of standardizing amyloid on PET scans, with 20 being roughly what demarks abnormality, and someone with Alzheimer's dementia having roughly 100 centiloids. And so you can see placebos in blue, treatments in orange. And you can see that lecanemab removed roughly 50 or more centiloids. Donanemab removed over 80 centiloids in the treatment period. They can effectively remove amyloid. Now, there is some evidence to suggest that removing amyloid also has some downstream biological effects. And so what I'm about to show you comes from Dr. Randy Bateman, who presented this at the Clinical Trials in Alzheimer's Disease Conference in 2022. And he uses a similar format where time is on the x-axis, roughly 18 months. And on the y-axis is this mean change in the protein of whatever we're talking about. And the treatment group is in the lecanemab is in green and placebo is in black. And here we're talking about phospho-tau. So this is sort of that intermediary between amyloid and then the tau in the neuron. And what we see is that those that were treated with lecanemab have reductions in this intermediary protein, both in the spinal fluid and in the plasma. Now we see NFL, so that's that axonal injury. We see at the end of the 18 months, there started to be a separation in the blood between the placebo and lecanemab. We see in the spinal fluid, there was a separation and a reduction in total tau in the spinal fluid, non-specific neurodegeneration. And then lastly, we see in the blood, there was a reduction in GFAP, so inflammation, and a reduction in spinal fluid neurogranin, synaptic dysfunction, downstream effects by removing amyloid. So this is all biology. And I know that the real question that we're asking is, are monoclonal therapies clinically meaningful? This is health is its own grand rounds. So I don't have time, obviously, to start discussing this in great detail. I was not invited to talk about that, just as a disclaimer. And so what we see here from the phase 3 studies, time is on the x-axis. On the y-axis is this mean change in the CDR sum of boxes. And for those of you that aren't as familiar, it's a composite of cognition and function as measured by the participant and the study partner. And what we see, placebo's in blue, treatment group is in orange. This is lecanemab, this is donanemab. It doesn't really matter because you can see the same thing. They're all declining. There's just less decline in those that were on the treatment group. At the end of the 18 months, the people who were on the treatment group had more cognition and function per their own rating compared to the placebo group. In lecanemab, they said it was a 27% reduced decline. There was a 26% slowing in cognitive symptoms and a 37% slowing in daily function. In the donanemab group, if you had low medium tau, it was a 36% slowing in the CDR sum of boxes and a 40% less functional decline at 18 months. And I think it's fair from a societal perspective to ask the question and debate, is this clinically meaningful? And that's what we should do for every drug, not just for Alzheimer's disease. But these two drugs are FDA approved. And so we're kind of past that point. We should still discuss it, but we're past that point because we're already seeing this in clinic and our patients are already asking about it. So at the individual level, this is where shared decision-making is so important because we really need to talk to our patients about the limitations of this drug, about the pros of this drug, about what this might mean for them. Because having MCI is much different than having mild stage dementia. Within mild stage dementia alone, it's vastly different. And this is where I think geriatricians are so needed, because having mild stage dementia with one functional impairment is much different than having mild stage dementia and all of your IDLs are impaired. And this is the conversations I have with my patients. This is why it takes me so long to be with my patients, and probably why more of my patients don't go on these therapies, but I do discuss them with everyone, and why I think function is so important. But I do think this is an individual decision and why it's so important for all of us to be informed about the drugs and to talk to our patients about them. So biomarkers in Alzheimer's are not new, but specific Alzheimer's biomarkers are changing this field. And amyloid and tau are diagnostic of this disease process, but in research, they're showing predictive ability for future cognitive and functional decline. Amyloid accumulation is consistent once it's elevated, and it does lead to tau development for most, if not all. This does need to be reproduced in other cohorts. MAB treatments remove amyloid and may be impacting downstream biology. So I asked the question then, other than MAB treatments, what else is impacting Alzheimer's biology? And this is where I want to talk about briefly lifestyle, because my own bias is that I believe lifestyle interventions are foundational to healthcare. I love lifestyle interventions. I think we should talk about them at every visit. And I think as geriatricians, we care about them because we focus on function. We focus on well-being. We talk about medications. And again, we are experts at multimorbidity. And when we look at the 14 modifiable risk factors that came out of that Lancet Commission, at least 8 of them are chronic health conditions. But I asked the question, are they really addressing dementia pathology or are they addressing something else? And the RAP study is also asking that question. So we are looking at some of these modifiable risk factors when it comes to cognition, but also when it comes to biology. And so Dr. Leon Du in 2023 looked at sleep and cognition. And so she had 619 cognitively healthy individuals who filled out validated sleep questionnaires. And then through cluster analysis, she broke them into 3 subtypes: poor sleepers, intermediate sleepers, and good sleepers. And then she compared them. And she found that poor sleepers perform worse in learning, short-term memory, executive function, and that PAC score. Didn't seem to impact their working memory. Now, my colleague, Dr. Ozioma Okonkwo, looks at cardiorespiratory fitness, sort of just fitness in general. And he found that higher fitness was associated with slower decline in verbal learning and memory and visual learning and memory. And in this figure here, you have time on the x-axis and visual learning and memory on the y-axis. And those that were more physically fit are in teal, and those that were less physically fit are in blue. And you can just see a slower rate of decline. This has been reproduced in many other studies too. He happened to find the effects were stronger in men and non-carriers of ApoE4. But what I think is important about RAP is that we also looked at the Libra score and cognition and biology. And for those that aren't as familiar, Libra, Lifestyle for Brain Health Index, is composed of 12 modifiable lifestyle factors. So 9 of them are risk factors, very well known and established for being risk factors for dementia. And you can see them all here, a lot of them being cardiovascular, along with depression. There's 3 protective factors: low to moderate alcohol use, which I do not agree with, high cognitive activity, and a healthy diet, which I believe is the DASH diet. And population and patient-based cohort studies have demonstrated lower Libra scores are associated with better cognitive function and lower risk of MCI and dementia. And we have shown this in RAP too. But Dr. Cody also looked at the Libra score and amyloid onset. Does that impact amyloid onset? And she could not find a relationship. She then broke RAP participants into tertiles, those that were healthiest, kind of middle, and then those that weren't as healthy. And she then looked to see if there's a relationship with cross-sectional amyloid levels, and she could not find a relationship. We then went back to sleep. And so Dr. Leon Du showed that poor sleepers had worse scores on measures of depression, self-reported health, memory complaints. They had worse metabolic metrics, higher BMIs, higher waist to hip ratios, higher insulin resistance. And when she looked at sleep and cross-sectional amyloid levels, she too could not find a relationship between poor sleep and amyloid. University of Kansas Alzheimer's Disease Research Center did a 52-week exercise intervention to see if exercise could impact amyloid accumulation. So they did an amyloid PET scan at the beginning, at the end, and it improved cardiovascular health. It improved a lot of those metrics, but it did not impact the accumulation of amyloid. So then what exactly impacts amyloid onset and accumulation? And what we're seeing is that ApoE4 carriers do develop amyloid earlier than non-carriers. In RAP, for every ApoE4 allele is about 5 to 8 years earlier. Age or sex at birth does not impact onset. We could not find a relationship between Libra, sex, and ApoE4 when it comes to amyloid accumulation. And Dr. Bethauser and Adney could not find a relationship between being impaired and not impaired and rates of accumulation of amyloid, meaning those with dementia are not accumulating amyloid faster than those who are cognitively healthy. Which asks the question then, well, what exactly is lifestyle doing for us? We know that lifestyle matters. We know that it's helpful, but what is it doing? And I think it really is impacting our cognitive reserve, is moving us from the red line to the blue line. So perhaps we're declining at the same rate, but we simply have more room before we reach this abnormality threshold, whether that's a symptom threshold or an impairment threshold. Hopefully, it might be impacting non-Alzheimer's processes. I'd like to think it's impacting vascular disease. Lifestyle may be impacting the onset and timing of tau. There's not as much research in that. I do think researchers here at UCSF will probably be the first to answer that question. But it doesn't seem like lifestyle is impacting amyloid onset and accumulation. And I'm emphasizing that point because what can impact amyloid accumulation is monoclonal therapy. And so to the person who called me an anti-geriatrician, I don't think monoclonal therapy is a silver bullet, but I don't think lifestyle interventions are either. And I don't think we should put our heads in the sand and think that lifestyle is going to solve everything. I don't think these things are mutually exclusive. I actually think they're complementary in the right people, knowing that these are not perfect. These are far from perfect. And that we need to have these conversations with our patients because they might want to try them and we have to be there for them and counsel them. But I don't think we should turn away from these medications because they're here, they were approved, and we know they can do something biologically. So what exactly is the role then in my world as this potential anti-geriatrician? So the fundamentals aren't changing. And I love this paper. I really wish I could meet Dr. Haggerty. So this paper in JAGS 2020, 8 key elements of memory care. And I'm not going to read them for you. But what I want to do is bring the curricular milestones back from the beginning of my talk and the entrustable professional activities. And for the sake of my voice, I'm just going to say CMs and EPAs. So I'm going to bring them back because I want to show you this overlap between EPAs and CMs in this. So I'm just going to highlight ongoing care plans, psychosocial intervention, self-management, treatment of other conditions. And look what geriatricians do. We know when to make the right referrals for mental health. We know when to treat reversible causes, especially depression. We treat our patients from beginning to end based on anticipatory guidance and goals of care. We handle cognition, function, and BPSD. We care about the function and well-being. We look at all of their health, their comorbidities. We help them with goals of care and making decisions. We focus on geriatric and the geriatric syndromes during all of this. That's providing palliative care, end-of-life care eventually. When it comes to caregiver support and coordination of care, a lot of these overlap, but we coordinate care across the many different healthcare settings that sadly many patients with dementia do go through. We skillfully facilitate those family meetings and we lead those interdisciplinary teams. When it comes to the assessment and medication management, well, we certainly know we know the difference between normal aging and abnormal. We know how to use the tests, the cognitive tests, the mood assessments. We know how to diagnose and manage dementia. And then we know about comprehensive medication reviews. So the allocation of our energy should still remain in these foundational elements, regardless of the advancements in the biomarkers and these novel therapies. But I would propose we need to update the EPAs and the CMs to include them, to incorporate them in what we do. And so for just for the sake of suggestion, I've tweaked some of the EMs or CMs and EPAs so that we would just see what it looks like. I promise this is how I'm going to end. Geriatricians know how to integrate patient goals and values, comorbidities, prognosis when discussing biomarker tests and novel therapies, including the strengths and the limitations. We perform, interpret, articulate the meaning of biomarkers as assessment, prognostic, and monitoring tools, and then we skillfully facilitate the return of these results to patients and families. We diagnose and manage the causes of cognitive impairment by integrating biomarker information in conjunction with our clinical history and cognitive testing. We care for the patient from beginning to end, providing guidance on novel therapies based on biomarker information and their goals of care. And we utilize and lead the interdisciplinary team in the management of patients who have learned their biomarker information and are on these novel therapies. When I talk to primary care providers, I show this slide to emphasize that the cognitive evaluation and care is a multiple step, multiple clinic process with ideally a nice handoff between primary care and specialty care, with primary care in blue and specialty care in red, with primary care being in this position to collect really meaningful information on cognition and function, health conditions, medications, but looking for reversible factors and doing some cognitive screening. And specialty care, working with neuropsychology, understanding the cognitive changes, getting biomarker testing, looking and getting that etiological diagnosis so that they can make referrals, start medications, including novel therapies, and then referring to clinical trials, because there's going to be more clinical trials. And I do believe that geriatricians can do every single one of these boxes. And if that's true, not one geriatrician, but the group of geriatricians. And if that's true, then geriatricians have to become experts in biomarkers and novel therapies too. That's my argument. And so with that, I thank you for your time, your attention. And if you ever get tired of listening to Eric and Alex, I do encourage you to listen to Dementia Matters, but I'm happy to take any questions.
Wonderful talk, Nate. Really clear and helped me understand a lot. Just to thank you for being one of our visiting professors.
Oh.
We provide you a plaque. It says a teacher affects eternity.
Oh,
so you can remember us. And again, just thank you for spending the time with us.
Thank you.
So let's open up for questions. I will take the prerogative to ask the first self-serving question. You'd mentioned it sort of ends about your lifestyle slide about moderate alcohol or light or moderate alcohol being protective. I have been told, since I do not drink alcohol, that I'm going to develop dementia. I've been told this on multiple occasions, but you said you didn't believe that it's protective. I'd love to hear sort of why you think that, or yeah.
Yeah. And so I think there's a lot of bias when we look at some of these studies. Why are people not drinking alcohol? And so is it because they already have liver disease? They already had, alcohol-induced cognitive change. And so I think it's a selection bias. Why are people who do drink light amounts healthy? Is it because of the socialization? Is it because they had better social determinants of health? They had more money. And so when we just look at the actual, like the biochemistry of alcohol, it's a toxin, right? It suppresses cognitive activity. So it doesn't actually make sense from a physiological perspective. And so relying on epidemiological data isn't enough. And so I think there's enough explanation that there's selection bias that I don't believe it. And I think I've heard better explanations. I'm trying to summarize those, that it's not good enough data to say it. And I think there's not a good biological rationale as to why it's protective.
Good to hear.
Yeah.
All right. Any other questions? Okay, we can do a Zoom question to start. Let's see if I can read it. Some would argue that because geriatricians can't distinguish the differences in dementia subtypes, that we're not equipped as dementia specialists. What do you think? Does it matter?
Well, I would say geriatricians could distinguish the different subtypes if we have a good team. I rely on my team to help me. So neuropsychologists are amazing with cognitive testing. The patterns are very helpful. And so I do think I'm able to help differentiate Lewy body disease and frontotemporal disease. In fact, a lot of that is based on presentation and the symptoms. I also think there's a lot to learn from neurology. I learned my physical exam from the neurologist. I can look for Parkinsonism. I can look for a lot of this. And so I do think we're capable of it. And when I'm in doubt, I refer to neurology. So I guess I don't think inherently I can't do it. So I think with the proper training and time, we could do it. And the team. So I really do think it's helpful to have cognitive testing. I want to be clear, though. I don't think mini mentals and MOCAs should be used to diagnose dementia. They were never designed for that. I know we use that to do it out of the sake of convenience, but I really do think a full neuropsychological evaluation is owed to our patients who want to know if they have MCI or dementia. And I think with that neuropsychological evaluation, we can do that. And I think a geriatrician can work with neuropsychology to do that.
Great. Other questions?
So you bring up that PET study that showed it changed management. So you have a biomarker that changed management. One of the things I worry about with biomarkers that it'll change management ahead of the evidence. So for example, the PET study, it increased use of drugs for Alzheimer's, drugs for MCI, and there's no FDA approved drug for MCI. There's no evidence that any drug outside of amyloid antibodies affects MCI. So do you worry we're going to see the same thing with these biomarkers, getting ahead of the evidence even before MCI if we're using them more often, similar to what they found in the PET scan, where again the biomarker worked, but it increased non-FDA approved indications of drugs?
No, I think that's a very fair point. And I think there's always concern for non-FDA approved uses. And I think that could very well happen. I would hope for people to be, more careful when it comes to such severe side effects as ARIA when we think about monoclonal therapies, but it could be used. And I know where you're going with this when it's prior to MCI. And for those that are interested, Eric and I debated this on Jerry Pal this morning. There are going to be results coming out either this year and then certainly in the next couple of years for people with subjective cognitive decline and asymptomatic in monoclonal therapy. And that will answer the question of whether or not there's benefit. And then we will have to have these discussions of, is this truly clinically meaningful and should they be on these therapies? And then it won't be ahead of the time. But for this time being, I do believe you're right. People who have a cognitive impairment, MCI and dementia, mild stage dementia, should truly be the ones indicated for these drugs. And I think but I also would argue too, we should be using true functional histories to delineate where in this process, this continuous process of decline a person is, not just a mini mental. I don't think it's fair to say, well, you have a mini mental of 24, you fit the criteria, let's put you on a monoclonal therapy. We're better than that as geriatricians. And we can say, okay, well, this is your cognitive testing. You have 1 or 2 IDL impairments. Let's talk about what that means for you. Let's talk about what the possibility of what decline looks like. Is this reasonable or not for you? Or you have MCI, but you're starting to have some of these inefficiencies here. What does that mean for you? Is this your goal? And I think ideally that more nuanced conversation, because it really is about function. We're not changing people's cognition here. And I think that is the conversation that should happen more than here's your mini mental score.
Great.
Nate, that was a great talk. I am. This is maybe uncool. I'm going to ask you about the thing that you said that you can't comment on, because I think that was the most interesting part about kind of the time course and amyloid chronicity. And so the specific question that I had was on, I guess, another poor form, two-parter. Where does the time data of that analysis come from? Because is that from a single evaluation and there's something about the amyloid isoforms that allows you to get a sense of how long that's been there? Or is it actually from the ADRC or NAC data of seeing the amyloid at various points? Because that really, knowing where the time point data comes from would really go a long way in my mind of kind of getting a sense of how reliable those estimates are. And the second part was that on those graphs, I didn't get a sense of the spread of the population, of how much heterogeneity there is in the decline trajectories. And so if you could speak to that as well.
Oh, you've asked really great questions. And it's not NAC data. So when you look at those group-based trajectory modeling and SILA, they are using their own cohorts because it's SILA is standing for iterative analysis. So they're modeling their own data to create that. And I can't speak beyond that part of it. I'm sorry, I can't do that. I can give you Toby Bethauser's phone number, or and he could talk to you about it. But you're bringing up a really good point as far as, how are we coming to that? I do think the reproducibility of that, and it's different scientists. It's not just one person who's doing it in these multiple cohorts, and that they're showing that this amyloid clock or escalator is being seen is powerful information. And then the heterogeneity, I think, is a really important point too. You were asking about each cohort and the heterogeneity of the cohort.
Yeah, no, I mean, I feel like, I guess I always, it's one of, this is maybe me just a cynic or a skeptic. When a graph looks that good, I'm like, okay, what? So yeah, what exactly is going on under the hood there to get the line, the dots to fall into that good of a line? And so I just wanted to get a sense of how much of a spread, because
Yeah, and I wish I could speak more to that piece of it. I was thinking about the different ways I could prepare for this talk, and I will say this part of it is beyond my wheelhouse as far as the stats go. But yeah, I can't go beyond that. But I promise that, I'm going to be sending you an email with more detailed information on that, because I do have access to the people who can put that together. Because you're right, though. Really key to my argument is the fact that when you are elevated, you continue to accumulate. I do think what's interesting is that, separate from clinical research, longitudinal cohorts, clinical trial research is also showing that 3 centiloids a year, that they're seeing this consistent increase. So it's being seen in multiple different settings. And so that, to me, is also not only interesting, but reassuring that what we're finding is true. But I agree, and I don't think you're being cynical. We're trying to find that it's not true. That's the whole point of this, right? And I think that's really important process. But if it is true, then we really are looking at this biological process. And if this is the process, if we are able to get a timeline, then that really makes a case for why we need to be able to intervene and address this.
Great. Well, I think that ends. I think we have run out of time for that final question. Everybody can email Nate if they have any further questions. But thank you so much. That was wonderful.
Yeah.